Hi, everyone, and welcome. Thank you for joining the Life and Breath Foundation speaker series. We are joined today by Dr. Gupta. Very excited to have him here for this discussion. Um, Abby, are you sharing slides? It doesn't look like I can see it yet. Thank you. So today we are going to be discussing the basics of pulmonary sarcoidosis. My name is Alexis Hall. I am a volunteer and family member of a sarcoidosis patient. Life and Breath Foundation exists to offer the sarcoidosis community effective tools to track their journey, decipher medical issues, and maximize their quality of life. Also, to provide a nurturing environment to those affected by sarcoidosis to share their experiences and to build more awareness within the medical community to combat the chronic disease. And what we do at the organization is we are volunteer-led. All of the money that we receive through our donations and sponsorships goes directly to supporting patients with sarcoidosis. Some of our services include monthly speaker series, which you can view all of our replays on the YouTube channel, Life and Breath Foundation. We also have support through our sarcoid experts and patient support through sponsorships and education, and very proud to offer our own Life and Breath planner. Now for our guest who's with us today is Dr. Rohit Gupta. He's an associate professor in the Department of Thoracic Medicine and Surgery at the Lewis Katz School of Medicine at my alma mater, Temple University in Philadelphia. He practices a broad range of pulmonary and critical care medicine. After joining Temple Lung Center in 2016, he officially founded and directs the Integrative Sarcoidosis Center of Excellence at Temple. His interests also include other interstitial and advanced lung diseases, pulmonary vascular diseases, and lung transplantation. He has been an active member of multiple clinical trials and publications in advanced lung disease, besides involvement in patient and advanced lung diseases. He is a provider of education at all levels. He has been named as one of the Philadelphia Magazine's top doctors since 2021. Outside of work, he enjoys playing lawn tennis. I love that. Music, watching cricket, and spending quality time with his family. Excited for him to have this discussion with us. But before I kick it over, just want to offer this brief disclaimer that this webinar will not give medical advice. No doctor to patient relationship has been established by talking with Dr. Gupta during this meeting. Our speaker does not know your medical background and can therefore not give you specific medical advice. Please speak with your doctor before acting on any of the information you hear this evening. And again, Dr. Gupta, thanks for being here with us today. I will turn it over to you.
Thank you for inviting me, and let me share my slides. I am Rohit. I'm at Temple Lung Center in Philadelphia. I direct the Sarcoidosis Center of Excellence here. And today we are going to just learn about the basics of pulmonary sarcoidosis. Let me see. Can you guys see my slides? Good. Okay.
Yes.
All right. So again, I'm going to keep this very basic and understanding that the slides might be overwhelming. I do put a lot of stuff there, but again, this is going to be an interactive session, and the slides are there for just discussion points. So I'll go quickly through these, and then I'll be open to many questions if possible. All right. So let me get started. Let's see slides. Yep. Okay. So disclosures are here. And again, this is just for patient education. There is really nothing which is a conflict here. I do have some consultancy, some grants. I have clinical trials, which I am PI on at our center. And the major disclosure actually is there are only two medications which are approved for use in sarcoidosis. But again, we are just covering the basics of pulmonary sarcoidosis at this time. So before we talk about pulmonary sarcoidosis, what is sarcoidosis? So you might have seen this image here and there on Google or something else, where essentially when you blindfold people and let them touch the elephant, you can see people saying, okay, this is that. But sometimes sarcoidosis is indeed like that, and you being patients actually know better than us when you keep on going to physicians, doctor after doctor, and saying, I have this, I have that. Somebody has to actually take a step back, open the blindfold, and try to see that you have a diagnosis which sometimes could all be unified to your sarcoidosis diagnosis, but many times it is not. So not everything when you have a diagnosis of sarcoidosis is related to it, but many times it can be. So we have to be aware of it, but we don't have to be like over anxious about everything. So it is an old disease. It remains enigmatic, though. It is a systemic disease, meaning multi-organ disease, or multiple organs can be involved in patients. It has a lot of variations and unpredictability. That's generally a rule rather than exception in this disease. It is found throughout the world, but variations again are present in the incidence and prevalence. Our thought on why this disease happens is that in genetically predisposed hosts, when they are exposed to some kind of antigen from outside, that triggers an exaggerated cellular immune response, which leads to granuloma. And granuloma is a ball-like structure which has multiple cells around that trigger or antigen, which kind of essentially walls it off so that it doesn't damage the body. But in doing so, it increases inflammation, and through the cytokines can lead to symptoms. And ultimately, any type of inflammation, when it gets repaired, it can lead to scarring. So it's a representation visually here that some different type of antigens, which could be infection, could be organic particle, inorganic particle, when they come into the body through a milieu of cells and cytokines, which are the chemicals secreted from the cells, lead to this granuloma or this walled ball-like structure made up of inflammatory cells, which leads to the symptoms. And if the body can clear the antigen properly and decrease the inflammation spontaneously or with the help of medications, the disease resolves. But if not, the disease can become chronic, disease can give problems, and ultimately can lead to fibrosis or scarring. So these are the ball-like structures, and these are along sides of your airways and the vessels. That's why it's called peribronchovascular in nature. And there are a lot of granulomas or tightly packed structures. So non-caseating, meaning there is no caseation or necrosis inside these granuloma, and these are granulomas of granulomatous inflammation, and that is kind of the hallmark of sarcoidosis. That doesn't mean that you have sarcoidosis. If somebody gets on biopsy these type of structures, that doesn't always mean you have sarcoidosis. There are differential diagnoses which we need to rule out before we make that diagnosis of sarcoidosis. So now moving on to pulmonary sarcoidosis. This is the form of sarcoidosis. As we talked about, sarcoidosis could be multiple organs. This is the most common organ involvement of sarcoidosis, causes most of the morbidity, meaning issues with the health, mortality, meaning death, and healthcare use. And there is a delay in diagnosis because many times there are non-specific features, and there is misdiagnosis of the disease. Um, the typical breathing test pattern abnormality is a restrictive defect, which is decreased DLCO. But sarcoidosis is very interesting that any pattern, even normal PFTs, are possible in the setting of the disease and symptoms in the patient. Now, when we do testing and when we try to get a diagnosis, bronchoscopy many a times is performed, which is, I'll show you some pictures in the next slide, which is where we go inside the airways, take samples, and that is very high yield for diagnosis. So the bronchoscopy, this is a bronchoscope, which is an endoscope which goes inside your nose or mouth. Sometimes we intubate the patients, meaning put them under general anesthesia, and through that tube, endotracheal tube, this scope goes in, goes down your airways. We look at the airway mucosa or the wall of the airway. How does it look? We go inside the deeper parts of the lung, we put some saline, take it back, send it for testing. Many times we grab a biopsy for looking under the microscope as well. And how do we grab the biopsy? It is through this forceps, which goes through the working channel of the bronchoscope. And now we also have ultrasound, so endobronchial ultrasound guided biopsy. So EBUS is called. So EBUS is a thicker scope and it has a working channel through which the needle can go. And under direct visualization, when we touch the EBUS scope to the wall, you can look at the lymph node, and under direct visualization, you can do the lymph node biopsy. This is how it looks on the screen, and then we can take samples. The chest X-rays in sarcoidosis are variable. The name of staging coined by Dr. Scadding in 1961. It's not really a staging, so it's not like a stage one has to go through two, three, four. Many times patients present with stage 4 disease, and even then they are sometimes asymptomatic. This is not like a cancer staging that, oh, I have stage 4 disease. Although stage 4 disease, the important thing is that the diseases, when they are more advanced, stage 3 and 4, they don't resolve per se. So you have to understand that the staging can be important for resolution of the disease, but it's not really a staging per se. So stage 1 is where you have just a lymph node enlargement, nothing else on the X-ray. Stage 2 is when you have lymph node enlargement, but also some dots, these nodular changes on the X-ray. And stage 3 is when you have only the parenchymal or the lung involvement. Stage 4 is when you have fibrotic changes. So you will see the pull, retraction, smaller lung volumes. You can see that this airway is pulled here. You can sometimes see cavities and stuff like that. So that's a chest X-ray in this day and age. Everybody gets a CT for this reason or the other. There could be subtle changes of nodules on the lung. There could be a lot of more nodules on the lung. There could be nodules coming up together, which are called galaxy signs. There can be sometimes alveolar sarcoidosis, which looks like pneumonia. And then there is obviously fibrotic sarcoidosis, where you have a lot of traction, pull on the airways, and you can see this, what we call as honeycombing. I'm going a little fast because, again, I want this to be more interactive rather than just me talking. So I'm just giving you an overview and then we'll open it for questions. Now, how does this disease evolve? So you can ask me, you have told us about the disease per se, what is going to happen to me? And I would say, a lot of this actually depends on your characteristics or how you have shown your disease to us so far. Which is counterintuitive that you are asking me how this disease will do, and I'm saying we'll have to sometimes see how you do initially to kind of predict it. But we don't have great other prognostic markers for the disease. So how the disease evolves, if you see on the x-axis is time, and the y-axis is your evolution of the disease. In yellow, it's inflammation, green is treatment, and blue is fibrosis. So let's bear with me a little bit. This is a little bit complicated, but we'll make it easier. So patients can have things like one where you have just inflammation and you might not be able to come to the hospital or to us in time, and your disease kind of resolves and you have no problems, or you have seen us and we say, okay, you know what, let's monitor, maybe the symptoms and disease will go away. Disease goes away. Number two is where you have the disease, you do get some treatment, and the disease gets resolved and never comes back. Number three, you have a little bit of inflammation going on, which causes some symptoms, but not enough to give you treatment, and that kind of just stays at that level. Four is like two, but you get intermittent ups and downs, and you get treatment intermittently. Five is where you keep on getting more and more inflammation, and we keep on trying one after the other agent, and we keep on going up. Six is where you have a little bit of fibrosis in addition to number four, which is not really bothersome to most of the patients. Seven is where sometimes the problem is, where there is low grade inflammation in the past, nothing major happens, but suddenly you start developing more and more fibrosis for whatever reasons. And that's the time when we say, okay, do we need to control the inflammation? But inflammation might not be the problem at that time. But even if we keep on going just against the inflammation, it doesn't really help. The fibrosis keeps on going and you might be in trouble. And number eight is when you came, you already had some fibrosis and the fibrosis remains stable, nothing to do kind of thing. So that's kind of in a nutshell, like how the disease can progress at different evolution trajectories. But there are some features which can predict that there could be problems in a specific case. So if the diagnosis is at age more than 40, if the patient is of African American race, because we do know that African American, as especially the women, are more affected and they have more propensity of having a chronic disease. If you have extrapulmonary disease, especially cardiac, neurological, and some other diseases as mentioned here, calcium issues, bone disease, um, requirement of treatment at the first time you are presenting to a sarcoidosis clinic, meaning that you were already kind of inflamed and you had enough disease per se. And when we say advanced pulmonary sarcoidosis, which we will talk about in a second, so I'll go from there. Now, when do you treat? Treatment doesn't always come with the diagnosis of sarcoidosis. You don't say, okay, you have sarcoidosis, you need treatment. We need to make sure that we only treat if there is a significant quality of life or symptom burden, or if your life or organs are in danger. So that's when we treat. And the goals of treatment are to regress the disease, try to stabilize or prevent the complications or progression of the disease, and prevent the complications or treat the complications. Those are the treatment goals. So in some patients you favor treatment, some patients you favor monitoring, and that's a very patient centric decision. Shared decision making is important in that. And what things we take in consideration are if the patients are really very symptomatic, if their organ function are impaired enough, or if we are feeling that the organ is in danger or the life is in danger. Clear cut activity of the disease, that we know that this is an inflammatory disease, we need to calm down the inflammation. It's a progressive disease that we have kind of monitored for a little bit and the disease is increasing. And in disease states, when we say this disease is not really going to just spontaneously resolve and it's causing symptoms or progression, so let's try to hit it. And then what do? You do steroids or steroid-sparing agents. And we'll talk a little bit about what treatments are available. But steroids are used in the patients who don't have a lot of comorbidities to kind of cause steroid problems, which sometimes are more problematic than the disease itself. So if you see, okay, I might need only a few months of treatment, sure, we can sometimes give the steroids. Responsive organs, especially like lungs, kidneys, etc., we can try to just do steroids. And if the disease is recently in onset, when we again kind of feel that it's going to be only for a few months, and then maybe we will be able to get off, then we can try that. But we don't want to have people on chronic, long-lasting steroids. So the schema kind of remains the same: glucocorticoids, so prednisone and other medications, steroid-sparing agents like methotrexate, azathioprine, leflunomide, mycophenolate, or Cellcept, and then biologicals, TNF inhibitors, repository corticotropin inhibitor, and rituximab. Essentially, clear therapy. It's more research-based stuff. We can leave that alone. There is a recent publication and methotrexate is actually also now considered that it can be given as a first line to some of the patients rather than just using steroids. We always assess for progression and medication side effect on each step, and we aim for the lowest steroid possible at each step. Sometimes, if the disease is severe, we might need to start combination though. So these are some of the examples, not going through this whole table. This is just an example of the medications which we can use, the dosages, what is the major toxicity, and everything needs monitoring. And we have to be cautious that we are not just saying, oh, take the medication, we leave the patients alone, and the patients come back after 1 year saying, okay, I've been on 40 milligram of prednisone all this time. So it's a joint venture. You and us have to partner together and to say, okay, we are going on a treatment. This is going to be a long treatment. We have to monitor carefully so that the risks don't outweigh the benefits in this situation. This is again not for going through, but this is a first step, which finally we have some evidence-based statement how to treat inflammation in setting of sarcoidosis. This one is for pulmonary sarcoidosis, and this goes through with level of evidence and all. Again, kind of the same as I showed before, but this I show always because there is at least some guidance now for us as healthcare providers, like what to use first and what next and stuff like that. Final word before I close. Actually, two main things. One is advanced pulmonary sarcoidosis, and then we'll talk a little bit about the future, and then I will close. Advanced is a term we use in sarcoidosis when a disease has significant risk of death or organ function loss. And on the same token, advanced pulmonary sarcoidosis is essentially the disease which has significant risk of pulmonary or respiratory failure or death due to lung disease. And obviously, with that definition, although only a little bit of proportion of patients with sarcoidosis are affected by advanced pulmonary sarcoidosis, it is indeed responsible for most of the healthcare utilization and the poor outcomes for sarcoidosis. What does this term include? When you have advanced fibrosis, pulmonary hypertension associated with sarcoidosis, respiratory failure, or other lung complications due to sarcoidosis. That's what we put in that bucket of advanced pulmonary sarcoidosis. There are some other terms like respiratory refractory sarcoidosis and exacerbations. We're not talking about them, but they are kind of similar, but exacerbation is just disease going up and down. Whenever we see a patient with advanced pulmonary sarcoidosis, we always have to be careful that we address that the new or worsening symptoms in these patients and patients with pulmonary sarcoidosis could be due to pulmonary sarcoidosis, and that can be divided into inflammation, fibrosis, pulmonary hypertension, infections, all those things, versus is there extra pulmonary sarcoidosis which is causing the problem, or is it complications related to treatment? And sometimes it's not related to the sarcoidosis or the medications. So we got to be really comprehensive in our assessment what is indeed causing the problems in a patient who has been diagnosed with sarcoidosis. And we assess looking at inflammation, looking at complications, trying to see if the patient has a poor outcome, and maybe we need to do transplant evaluation. Sometimes we need to look at the other organs and symptoms and then do some specific management, recognize the comorbidities and treat them and prevent complications. So these are the assessment and goals, what we want to do. And then once we decide that, then we treat them with the specific treatments and all. So multidisciplinary sarcoidosis center are important. Patient care research and education are the three pillars of these type of centers. WASOG, which is the World Association of Sarcoidosis and Other Granulomatous Diseases, they have now designated centers to be sarcoidosis clinics, and for centers which have a lot of research and all to be centers of excellence. And these have defined team of specialists. They have set algorithms for diagnosis and management. They have patient support groups, educational opportunities. And I think the future lies in collaboration with multiple centers, trying to get on with registries, biobanking, try to collaborate in research and clinical trials to advance the literature on the disease, to find the solutions of all the questions which you and we ask in this disease, and then go from there. I don't want to be totally pessimistic. I am optimistic in the field that there are disease models which are coming up. We didn't really have great models so far. There is a lot of epidemiological research going on. There are prognostic models being formulated now. Wells law, which is that when we only treat in those two settings which we talked about, targeted treatment in different type of settings. Organ specific research is ongoing, like cardiac, pulmonary, neuro. Quality of life and patient oriented research is really big right now, and we are trying to figure out what is important to you guys rather than we feeling that we are treating the disease. Collaborations, as we talked about, and the other societies. are coming in to pitch in finally. The problem with this field has been lack of funding, lack of interest. I think that's starting to change a little bit now, and there are clinical trials which are happening. And I'm very happy that in the last 3, 4 years, we have seen multiple clinical trials in this disease field where I had seen none before that on a bigger scale. There might have been smaller studies, but in the last 4, 5 years, we have seen multiple studies, and hopefully we can turn the corner here. Um, and then our aim is to move from expert-based recommendations to evidence-based, patient-focused, and individualized care in this field. So there are multiple things which I'm not going through, but there, as the list I'm showing you here, are multiple things which have been completed, some things which are ongoing, but there are medications in clinical trial currently, and I would always encourage you guys to talk to your physicians to see if you would be eligible for any clinical trial, because this is how we will learn, you will learn, the community will move forward. This has been a major barrier of this field not going forward because of lack of interest, lack of funding. Now there are clinical trials, and we really had difficulty in enrolling in these clinical trials in the beginning. But I think we are now turning around and saying that the patients are interested and are keen to be a part of research trials, which I think is very important. That's how other aspects of medicine have evolved, and we want sarcoidosis to evolve as well. So take-home points, it's a heterogeneous, multisystem, granulomatous disease with an immunological basis. Pulmonary disease is responsible for most of the morbidity and mortality. Multidisciplinary approach is needed for complicated patients, and establishing collaborative research networks and centers of excellence are critical to moving the field forward. So I know that I went very quickly on the basics, but I wanted to keep more times. So let's open for questions.
Thank you, Dr. Gupta. That was very informative,
Oh,
and
you're
I
welcome.
loved hearing about your optimism and all of the research. That's wonderful. There was a question about where individuals can find information about the clinical trials.
So if you just type clinical trials.gov on any like search browser, search engine, or like Google and all, it opens up this government site, which is clinical trials site, where every clinical trial which is being done on a bigger basis has to be registered. So you open that page, clinicaltrials.gov, and Alexis, if you don't mind putting that in the chat box so that people
Absolutely.
know, that would be great. So that site, when you open and then you write in the disease sarcoidosis, and then if you put enter, it will show you what studies have happened, what studies are recruiting, and you can see where they are happening, and then you can contact those centers. Otherwise, ask your physicians or your healthcare providers that I am interested in studies. Do you know? And they can connect to centers where they do studies. So in our at our center, I'm really happy that we have a lot of patients who come from outside just for research as well. It's not that they have to transition their care to our center and all. So centers are generally open to that, and there's always a difficulty in enrolling for clinical trials. So nobody is going to say no to you. So even if you have to find a center which is a little far, many times actually it is compensated for. So, work-wise, financial-wise, I think we really need to think of this as a major, major option for us. Whatever.
Thank you. Thank you. And that's already in the chat. So we have the link for everyone who's with us live. Another question that was asked during your presentation was, has there been a thought of using keyhole surgery in order to perform a bronchoscopy if the normal method cannot be performed?
Keyhole?
Mm-hmm.
Um, I don't understand keyhole. Like what exactly? I am looking at the question now. Has there been a thought of using keyhole surgery? I'm not sure if the audience is asking about like an approach from like percutaneous or skin wise. There is something we call mediastinoscopy, which is a cut here, and then you can go in and take the lymph nodes and all. So there are only a few approaches. One, as I showed you, bronchoscope, which goes inside the lungs and all. The cut here, mediastinoscopy, can take the lymph nodes. There could be accessible lymph nodes and skin biopsies which can be done. But if you really need to get lung biopsy, you can actually go through the chest wall, like radiology wise, and get a lung biopsy as well. So I'm not really sure what keyhole means, but I think you're referring to laparoscopic surgery, which is actually a bigger surgery if you think about it, which is also when you go make incision and with the camera and all, you visualize and then you take bigger pieces of biopsy. So I'm not sure if.
Thank you. Another question was, can you discuss more about flares? How can you tell if it is a flare or an illness? Is there a
Yeah.
difference?
So great question. So flare, when we use flare or exacerbations in the medical terms or medical field, when we use that term, that really means that my disease was like this, steady, and now I'm feeling worse. But that worseness will, worse feeling and all, whatever is going on will go back generally to kind of your baseline. So it has to be differentiated from an overall progression of the disease or worsening of the disease. If your disease is just going like this, where your symptoms have been progressing on weeks, months, years basis, that's not an exacerbation or flare. Flare is sometimes when you have no medication or even when you have medication, but you were stable, whatever your baseline is, and then you felt worse and you needed some treatment to come back, try to come back to that baseline. Many times, not many times, sometimes it's not possible to come back to the baseline, but most of the time it is. So it is kind of the same type of thought process in COPD and other interstitial lung diseases, that people can have worsening of the disease and hopefully we can come back to baseline. But that's different than the disease progression or continued inflammation from the disease aspect, if that makes sense.
Yes, and another follow-up, there was another flare question. It says, what symptoms show that I'm in a flare since the ACE test never played a role in my diagnosis?
Yeah, the ACE and all the other biomarkers in the blood, unfortunately, are very problematic in sarcoidosis. So if your ACE was never elevated, it might not be useful. But if somebody's ACE was elevated, it can sometimes mark the disease activity. But again, if the ACE is elevated and you're doing great, I don't care about it. So we treat patients, we don't treat the tests. So it's just a marker. So let's say if the patient is saying, "Oh, I feel worse," and then you can use some biomarkers, great. But unfortunately, sarcoidosis, we don't have great biomarkers. There is a newer test called serum IL-2 receptor test, which might be a little bit more sensitive and specific for sarcoidosis. But in your case, if your question is what would flare look like, flare would be just worsening of your symptoms of sarcoidosis from your baseline. That's a flare. If that needs medication, but sometimes it has to be differentiated because people can have different reasons of flares, and also the flare has to be sometimes just be differentiated. So if I have pulmonary sarcoidosis, I get a viral infection, I might feel more, worse than somebody else who doesn't have pulmonary sarcoidosis, and they might have just a regular cold or something. I might actually feel even worse. That might be a flare for me. I get some medications, go back to baseline. That is a flare, not just persistent worsening of the disease.
Thank you. There were some questions about both sauna usage and ice therapy. Is that recommended for pulmonary
I don't
sarcoidosis?
think there is any guidance or guideline based on literature per se. Ice therapy, I don't know what ice therapy means. Is it just like the ice, like when you take the dips in ice kind of thing? If that is the case, I don't really know if there's any data to support that. Saunas, I don't think would be helpful. Now, if you say to me that if I do cold or hot or this or that, and that makes me feel better, sure, do it. If it is not injuring your body, if there is no long term risks which you know or can understand, and obviously you can talk to us always about that, um, then that's fine for comfort type of, or the symptom alleviation type of thing, but not really to change the trajectory or decrease the inflammation of the disease. I don't think so.
Okay. Any medications or things that I can do for a severe cough with my pulmonary sarcoidosis?
So cough can be problematic. Cough in any type of interstitial lung diseases, including sarcoidosis, can be multifactorial, right? So we as lung doctors, we always look for other stuff as well besides the lung disease causing the cough. So first, let's talk about sarcoidosis, how it can cause cough. It can be causing cough because of airway disease like asthma. It can be causing cough because of parenchymal involvement, like the lung involvement itself, meat of the lung, with those nodules and all. So those generally respond to treatment, which could be oral treatment or inhalers and all. Now, some people actually have a lot of acid reflux, which could be actually silent. They could be on medications which can cause cough, like ACE inhibitors, which end with pril, ramipril, enalapril, lisinopril kind of stuff. People can have runny nose, postnasal drip, which can cause cough. These are very common silent things which can be cause of cough in patients with interstitial lung disease. So you have to kind of differentiate whether it's from the disease, whether it is from other stuff. You try to target that. Obviously, supportive measures can be given, but there's no real great medication just for cough in the setting of sarcoidosis. You have to kind of identify the reason and then try to target that.
Thank you. You discussed a little bit about this, but the question submitted was any new treatments on the horizon, and specifically, how do you feel about the infliximab, if I'm pronouncing that correctly, infusions?
Yeah, so there are treatments on horizon. Unfortunately, last one or two studies which just came out were negative. But again, I think one of the problems in sarcoidosis are endpoints. Like, in a disease called IPF, idiopathic pulmonary fibrosis, you just have an endpoint of FVC, one of the markers in the breathing test. But that's not how sarcoidosis is. Sarcoidosis is much more patient focused. So you can't just take one number and say we failed. So the studies are trying to make composite outcomes or primary outcome as steroid reduction and all. I think we don't have great outcomes and medications are failing because of that. But there are studies ongoing, and these treatments, which are quote unquote failed, might actually be useful for some of the patients and all. So some treatments would be on horizon. I think TNF inhibitors, including infliximab, are good medications for sarcoidosis. We have seen that clinically that they work very well. Inflammation goes down and all. Obviously, everything in sarcoidosis we do has the potential to decrease your immunity and in long term cause problems as well. That is why we always weigh the risks and benefits. So you have to be careful about that. But I think there is optimism. There are treatments. There are multiple treatments which are being tried right now.
Another treatment related question was about Humira, and specifically, do those injections put you at risk of healing complications?
Sure, healing, like wound healing, probably not so much, but again, our healing, our attempts of fighting infections and all is all mediated by inflammation. So if you're trying to target that pathway of decreasing inflammation, those things can indeed be affected, right? So infections are probably the most common problem and most important problem when we treat with anti-inflammatory or immunosuppressive therapy. Wound healing can sometimes be a problem, uh, but some things have more than that, more than others. So prednisone itself or steroids themselves, they are not benign medications. While we use them very freely, they can impair wound healing. Other medications, including Humira and other agents, can impact wound healing. But again, it depends on what type of wound is being talked about. Because if we reduce and decrease or stop the medication, your inflammation might go up. If we don't do that, your wound healing might be impaired. So it all depends on how big your incision, what type of surgery, etc., etc.
Thank you. One of the live questions was from an individual who had a lung granuloma for 20 years, but now is seeing it progress to rib cage pain as well as some neurological problems. Would they benefit from visiting a research center such as yours?
So, sure, I mean, sometimes the disease can progress, sometimes it can go to different parts, or you can find it in different organs and all. Um, yeah, for sure, centers which are more experienced in sarcoidosis, the sarcoidosis clinics and centers of excellence would be able to probably help more than sometimes community and local centers. And you can find a local, like whatever center is closer to you. But I would also say the question, if you just say research center, I think there is no research study for neurosarcoidosis per se right now, which would be eligible for this type of setting. But yeah, if you're talking about a center of excellence, it might be better because there is collaboration between different specialties. So multidisciplinary collaboration could be helpful for this type of issue.
Thank you. There's another individual who now has sarcoidosis in lungs, bones, and heart. They were under the impression it only attacked one organ at a time. Can you speak a little bit about that?
Yeah, no, sarcoidosis is very variable as we talked about. It can have multiple organs at presentation, it can have one after the other. And by definition, you generally have more than one organ involvement if you have sarcoidosis. Now, if we look enough, we will find more than one. But sometimes we don't look hard, sometimes we don't need to look hard because, again, we are not just finding stuff, we are trying to treat you. So, if it is not very important or very symptomatic, we might not need to find it. But again, to answer your question, it can affect anything, anytime, anyway. So it's a very heterogeneous variable disease.
Thank you. Um, there's a question about if it's possible to have granulomas in the lung but not be impacted. This is a very active individual that asked this question.
Yeah, I have a lot of patients who have a lot of radiological or other test based abnormalities. Again, we don't treat tests, we treat patients. So if you're very well, we might not need to treat you. But if the disease keeps on progressing, it might catch up to your health. So that's when we try to monitor. And sometimes we have a discussion with the patient that, we have monitored enough, disease keeps on going up and up. So maybe it's time that we try something and see what happens. But that's a therapeutic trial type of thing if you're not having symptoms. Or we can wait and wait if it doesn't resolve and you become symptomatic, then we can do it.
Thank you. Is blood testing of your calcium level an appropriate way to monitor the disease if it's active or not?
I don't think it's an appropriate way to monitor the disease, but it's an important thing to screen for calcium dysregulation in sarcoidosis. Some people, it might be fluctuating as the disease activity goes up and down, but it's not generally the case. It can be in some patients.
Yeah. As a follow-up, when does a doctor know how to test for the spreading of sarcoidosis?
Yeah, I mean, we screen patients for other organ involvement. So we generally, when we do follow-up visits, every year or so, I screen for, like heart disease, calcium. We at least have eye doctors see here and there to just rule out for ocular sarcoidosis and also. And also, most importantly, if you have some symptom which we think could be suspicious for sarcoidosis, then we need to screen.
Thank you. I'll try to get one or two more questions in. I know we're coming up to the end of our time with you. What is the best way to identify pulmonologists that are knowledgeable in sarcoidosis?
Yeah, that's a little bit difficult. I mean, one of the ways is trying to find centers, sarcoidosis clinics, sarcoidosis centers of excellence, And FSR, which is Foundation for Sarcoidosis Research, has on their website like people who are interested in sarcoidosis. So I myself have put my information on the website, but again, that's probably not the best way, but that is probably the easiest way. If you know, like if you search medical literature and those people are on the papers and all, if they present here and there, if they are interested in sarcoidosis, if they are at centers. I think that's how I would think about this.
Thank you. And final question is, do you recommend a certain diet or vitamins for pulmonary sarcoidosis patients?
It's a great question because we are what we eat, drink, and breathe, I guess. So it makes sense to me, but there's no data on it. But I think uh, cleaner, healthier diet overall. Not because I want people to follow this diet or that diet, but I think a lot of stuff which we are seeing nowadays, chronic inflammatory diseases, cancers, and all, I think a part of me feels that there's something going on with the environment. I think much of it has to be done with processed foods, drinks, our polluted environment, and all plastics, microplastics, and I think those are important to consider. So whatever works for you, whatever you feel is a good, healthy diet, in my opinion, it might be different. So I don't want to give you my opinion, but again, trying to reduce ultra processed stuff, trying to reduce a lot of meat, that would be my thought, at least from my side. Again, depends on each individual and what they can what they feel is right for them and what they can do for them.
Thank you, Dr. Gupta. This has been very informative. Before we close today, just wanted to see if you had any final thoughts.
No, I think this is great. Thank you for inviting me, and questions were great. So I hope that we were able to at least have the basics and give some answers.
Thank you all. Thank you everyone for being here with us live today. And if you could take a moment to view our website, thelifeandbreath.org. There are some resources such as the planner that we discussed and the information about the sarcoidosis support group. Thank you all. We hope to see you soon.
Thank
Thanks,
you,
Dr.
guys.
Gupa, for your
Okay.
time.
Oh, you're welcome. Thank you. Bye.